Hey, Rich. How you doing tonight?
Good evening, sir. I'm doing well, thank you. We finally thawed out in Texas here. Had that week of cold weather and snow and everything. So, 75 and sunny today. But yeah, it was crazy, crazy week there, all over the country.
Yeah, it was in the mid to high 70s here.
Yeah.
So it was pretty crazy. We're just letting everybody get logged on. We're going to start right here in about 10-15 seconds of it. Just letting everybody get logged on as we hit the broadcast button. Hope everybody's doing well and they're excited to learn about simplified dental sleep medicine treatment steps this evening. We've got a lot of good information for you. So looks like.
Yeah, and some of you people out there are just brand new in this, and you don't even know what question to ask, and you may be afraid that, it's kind of a stupid question. There are no stupid questions, so just go ahead and ask them. Type them in the question box. That works a whole lot better than the chat, and I'll be answering some of them. We have a team from DS3 on here who will be answering some of them as well. So I just encourage you to ask away.
Absolutely. Well, I think most people are getting logged on, so we'll go ahead and introduce ourselves while that's going on. I'm Dr. Guy Yatros. I'm a dentist. Rich and I are both dentists. We've been doing this independently for over 20 years now. And I should have told you, Rich, I had my original sleep patient that I treated 21 years ago, came in last week for a new dental device. 21 years later, she's on her third or fourth device. So I don't think I'll have to kind of get her in the picture maybe for the next webinar, but she's still doing pretty well. We've learned a lot over the years, and we've learned a lot of what not to do. I'm going to share that with you tonight, and we've learned a lot of things what to do. And I think if you will listen to what we have to say, we're going to show you at a high level today, or tonight rather it is, how to do dental sleep in your practice and what you need to get in place to make that happen. So how are things out in Texas? I'm in Anna Marie Island, Florida, and Rich is out in San Antonio, and we're both that's all we do nowadays is dental sleep in our practices.
That's all we do. Yeah, all day, every day.
Right. And you will get CE for this, so a little housekeeping while everyone's getting logged on. It should come into your email within the next 48 hours. If you don't see it, go check your spam folder. For some reason you still don't see it after that, then please, you can contact us. I'll give you the contact information at the end of this webinar. And the next webinar is going to be on oral appliance side effects. And this is often a subject people really want to know a lot about. And so we'll talk about specific things you can do to help prevent side effects from happening. And then once
You still there, Guy? Cutting out a little bit. Lisa, can you hear Guy?
No, he's cutting in and out.
Okay. Yeah, Guy, if you can hear us, we can't hear you yet. We can't see your video. Your video is locked up. So if you can hear me, I'll kind of take over here, and you can just keep changing the slides as we go along until your internet comes back. So yeah, the side effects, that's probably, besides insurance, the next most important topic that we get questions about. You back, Guy? I can't hear you. You muted?
Yeah, it logged me back on, then it muted me. So we're good now. I switched to a different internet. I have like 3 of them in the house here. And so I think maybe we'll be back up and running here. So I apologize for that. You can hear me okay now?
Yep.
All right.
Loud and clear.
Let's hope that stays that way. So go ahead. What were you saying, Rich?
No, probably insurance is the most popular topic that we get, how to deal with insurance, but side effects is probably the second most. And I think, Guy, that's one of the things that probably scares a lot of dentists away from doing this. Hey, I heard it makes the jaw hurt, and it does this. And what do you do if one side hurts or both sides hurt? And those are the types of things that we go over. And there's a lot of good information in that one as well.
Absolutely. All right, I'm getting my chat open back up here. Sorry that when it rebooted, it moved everything. I think we already mentioned you can put things in the chat if you want, but really the questions will be better off in the Q&A. So, all right, sorry about the minor delay. Let's move on here with, not probably the first time we've done this for some of you, but I still think it's worth asking. How many of you, I'm sure most everyone screens their adult patients for oral cancer. And just to see if you can still hear us out there, we're going to do a poll to see how many patients you identified in your last year at being at risk for oral cancer, and maybe getting them to go get us a evaluation by an oral surgeon or do a biopsy or so. And we'll wait till give it about 5 more seconds.
Hey, Guy, I think I practiced general dentistry 13 or 14 years. And I know for me, it was maybe one a year. You know, we saw something that just looked really nasty, or, you know, we thought we should biopsy. So,
well, I think everybody can see that that the answer here is majority is 0.
right.
Second category 1. So right in line with what you're saying. And the reason is because the incidence of oral cancer is about 1 in 1,000. And so if you have 1,000 adult patients, well, you're going to find maybe 1 a year with that. And what I like to ask when we do live courses, which we'll talk about some live courses that we're doing, or live and virtual courses that we're doing, let me remove that so it doesn't clog up our screen, is why do we do oral cancer screenings? And the most common answer is, well, we care about our patients. And then people say, well, we don't, you know, it's deadly, and a lot of other things. And then people say, well, it's in the mouth, and it's our job to do that. And if we don't do it, we're probably remiss in not doing our job. And so for those of you, or some of you may be further down the dental sleep process, we'd ask if you're actually screening. So if you're not doing it, then maybe your answers won't be relevant. But if you're screening your patients for obstructive sleep apnea, how many did you find in the last month? Not in the last year. I'm going to switch it to the last month because the polls will be so one-sided if we don't ask it that way. And I'll wait till we get a similar number of people respond. I think we had about the same number here, given there's still a few people putting it in. I think we got enough to make an assessment here. And look at this. 4 or more is the overwhelming majority of the people that you'll find who have obstructive sleep apnea. And that's not a mystery, because 1 in 5 adults has obstructive sleep apnea, pushing 1 in 4, 20% of the adult population. And so this is very needed. And when we ask each of our people at these live meetings where they can interact just a little bit more, I'm going to stop sharing that so it won't clog up your screen there. Why do you do this? Well, because we care about our patients, because obstructive sleep apnea is deadly. And I think the one that we have the biggest trouble with at times is it's in the mouth. Is it our job to do this? And when I look at what happens on a patient when they relax and they get to the deeper stages of sleep, and you see this happening, I want to emphasize that if you want to do well in dental sleep, the sooner you recognize that this is our job, that no one else is screening these patients for obstructive sleep apnea, sleep disordered breathing, that this, I'm going to repeat that because I think it's that important, that this happening at night falls right into the wheelhouse of dentists, then it's going to become easy for you to do everything we're going to teach you tonight. And I'll even say that in a negative way. If you don't accept that this is your job, then you're going to have challenges because the patients are going to push back and you're going to feel uncomfortable. But once you accept this is your job and you believe that this is what you need to do, then we're here to help you fill in those pieces tonight, because then all you need is a system and to be prepared for walking through the steps of dental sleep. So just really 2 parts to it, believing in it, and then the steps that we're going to give you to put all these moving parts together. And if you don't have them all together, you're going to be frustrated, but we're going to give you a system and a process that you need at a high level to bring dental sleep into your practice. And speaking at a high level, we have been talking about the 4 pillars. I mean, the foundation of a successful dental sleep medicine practice for quite some time. And you know, we might sound like a little bit of a broken record to some of you that have heard us before, but you know, it really hasn't changed. The systems within these pillars have changed, but if you want a successful dental sleep medicine practice, you need systems and team members to screen your patients, to identify those at risk, to test the patients. That's gotten a lot easier, way better than it was even a year or 2 ago. Then you need a way to treat them, and of course you need a way to get paid for that. And it sounds simple, but we're going to dive a little deeper into each of those. Again, if you have any questions, feel free to put them in the Q&A as we get going. We're going to give you plenty of opportunity to ask questions, and we will stay on at the end to live answer any ones that you have. So, Rich, I've done a lot of talking. That's not unusual for me.
Yeah, let me add to that, Guy. We could talk for 6, 7, 8 hours about each one of these pillars. So, don't think you're going to learn everything there is to learn about sleep medicine tonight. If you're new into this and you're just learning, again, these are the foundations, and once you figure out a way to screen your patients, and then you got to have a way to get them tested. And Guy said, hey, this is a lot easier now than it used to be. And it really is, because the barrier to getting, we were talking about this at my office today, Guy said, it used to be about 10 months to get a patient back. We'd say, hey, you got to see your doctor, and they got to refer you to the sleep doc, because that's where your insurance works. And that took 3 months. And then it took 3 or 4 months to get a sleep study done. And then it took a month or 2 to get the report back, by the time you were done. I mean, we have ways to do this now, Guy, where we can get it done in 10 days. We get this whole process done in 10 days. So to go from 10 months to 10 days, but you still need a system for how to do that. And we're gonna hit this at a high level today, but again, you're gonna get the foundations.
Yeah, and I'm gonna say what you'll hear is, if you come to one of their virtual courses, you're gonna hear this, and I don't mean it to be totally in a sarcastic way, but you don't know how good you have it, because these systems are much easier than when Rich and I started doing this 20 years ago. So we're gonna walk you through some of the steps that you need. You need a way to screen your patient. You need a way to test them. But then you need a way to sit down and go over those results with your patient in a meaningful manner, to where we decide who are good candidates for treatment, and getting those that are good candidates to say yes to treatment. Then we need to do a dental sleep medicine exam and take impressions or scans, as most of us do these days. We need to deliver the device and how that goes. And then we need to do some follow-up with the patient, maybe for symptoms and for testing. And then we need to see our patients on a regular basis, because apnea is a progressive disorder. It gets worse with time, maybe as much as 20% every 5 years. So we need to keep following up. This used to take me hours of my time in my practice when we first started doing this, because we didn't have systems for it. But nowadays, if you have a good system in place and team members doing this, after you've got those in place, this should take, from start to finish for a treatment, just take less than an hour of your time, certainly, to provide a life-altering, life-saving, and meaningful service to your patients while making a profit. And it's not like we're competing with each other. I think that's one of the things dentists are like, oh, a guy down the street's doing veneers and Invisalign, and
another dentist just moved in down the street. Yeah.
And all stressed out, right? I've trained dozens of dentists within 5 miles of my office how to do this. And there's some of them doing quite a bit of it, but it doesn't matter, because 1 in 5 adults has this problem. There's such a need. All you need to do is find a way to start identifying those patients. Even if you just start within your own office, it can make a big difference. And I think it's not only the best thing to do to jumpstart your practice, it's the right thing to do, because this is one of the things that's broken in this system, where obstructive sleep apnea is one of our country's most significant untreated, undiagnosed medical problems. And it starts with the fact that most people don't know they have it. As much as 85% of the people who have this problem don't know they have it. And I think dentists, we believe, and I think you'll believe as well, that dentists are in the best position for helping identify these people who are at risk. And if you're not doing this, you're not only not helping your patients, you're losing some money on doing this. Red flags, Rich. I think I made this slide with your help 20 years ago and have added to it over the years. We're going to talk about a system in a minute, but I think more important than the system, whoever's going to be involved in this process in your practice needs to just get it in their second nature that certain things are associated with a risk for obstructive sleep apnea. And so when you see something like high blood pressure, it should jump out at you. Well, okay, sure, there's other reasons for that, obesity and so on, forth and so on. But it's also a risk factor for obstructive sleep apnea, and you need to be thinking about that. When you see someone who has diabetes, obesity, all the things, I'm not going to read everything on this list, but just reviewing the medical history, if you look at the things on the left side of the screen, those things should jump out at you. And I have some percentages there. Those are from some studies that show kind of the prevalence of that. So AFib is about 50% of the people with AFib have obstructive sleep apnea. So whoever's going to be involved in the screening process needs to really know this stuff second nature. That just is, it's coming to them when they meet people out. Clinically, we'll talk about some things at a high level for the exam that you can look at too.
I think it's a good idea. Put that slide up again. You guys take a picture of that. It's not a bad idea to take something like that medical history in the clinical. You can just put those signs up on the wall in the hygiene room, because a lot of people go, hey, what's that thing up there for? Well, do you have any of those? Yeah. Well, as a matter of fact, I'm sleepy all the time. I got blood pressure. My wife says I snore all the time. So, I mean, sometimes it's as simple as that, finding a patient.
Absolutely. And we have posters we can direct you to or help you with that have this stuff. Hey, do you have any of these things? We could get really granular on how you use this, but I think today what we want you to realize is you need to know this. I think, Rich, what you said there, take your phone out. I'll leave it up for a second more, take a picture of this. This is one of the things that I did when I first started doing this. I printed this out. I put it on my desk in my office. I put it in each of my operatories. And so that I would just get used to saying, someone has had a stroke or has GERD, and I should be thinking, hey, they're at risk. Doesn't mean they have apnea, but it's another tick mark in the pendulum's weighing out that they may have it. Now we're going to teach you a system that uses this information, and there's other systems out there, but we'll teach you a system on how you can use that information to really pretty rapidly sift out or screen the patients who are at high risk for this. And it starts with having a system to identify who's at high risk. There's a lot of ways to do it. We'll talk about the way we do it in just a moment. And then you need to have a person and a system, or persons probably in your office, team members, yourself if you're the dentist, or team members who believe in this, believe it's your job, and have that knowledge to be able to sit down with the patient and go, hey, you're going to have these risk factors. We need to get you tested. And the patient needs to agree to the test. And then you need a system for the testing. And now you can go treat the patient. I do think that the dentists typically want to jump to the treat too much. They want to rely on their models. They're comfortable with treatment. They're not comfortable with these other systems as much. And we're going to help you walk through those. And by the way, you probably need to have a system for billing too, because if you want to get paid and stay in business and pay your bills, you probably need that as well. So those are the steps that you need. A screening system, Rich, we looked at dozens of systems when we first started doing this. We're coming out with a new one that's going to be available for websites and so forth. I don't know that it's the system that's that important as much as it is having
the execution of it.
Yes, absolutely.
Yes.
It's a system's not anything that if it just sits there. You just need a way to pretty quickly assess your patients who are at risk. We have developed a cloud-based screening application that we took some screeners that were already validated. You can give that to your patient either with a tablet like you showed there, or you can do it on your computer with the patient in the operatory. And at the end of the day, when they fill out this questionnaire, they're going to get us something that looks like this if they are at risk for having sleep disordered breathing. And so what I like a little bit better than some of the forms you can use, which stop, bang, well, we utilize Epworth and ours, but there's Berlin, there's a lot of questionnaires you can use out there. But what I like about our system is the computer, is the patient's holding that in their hand. When you say, hey, we're going to update your health history, is what we usually tell them. Hey, we need to have you update your health history with these questions. And now they're holding that in their hand, or it's on the big computer in your operatory, however you do this. What do you think the patient's going to do when they see that?
Well, they'll believe that computer more than they believe me telling them, hey, what severe risk for what? Well, that's exactly the question that you want them to ask.
Right. And I love people asking me questions that I want to tell them the answer to. And if you can find a way, wouldn't it be nice if you get your patient to say, what about my hole in my tooth? Well, you need a crown. That's a lot easier than tell them they have a hole, they need a crown. So when you can get your patients to interact in that method, it really helps with the patient accepting the treatment that you're offering. You can't offer treatment until patients are ready to accept it. So in this case, they go, what does this mean? I'm severe risk for what? Well, you're severe risk for airway problems because of, and you would hit the button here, I think. I don't have that slide because it's an overview, but you would hit this button down here where it says view results, and we'd have all the reasons why that person's at risk. And that skilled person who knows those red flags would say, oh, it's because you're sleepy and because you're snoring and likely your airway's closing off. And at times, it's a very good chance that you're not even breathing at night.
Yeah, and then pause for a minute.
Yeah, my internet didn't tear up again. That was just me shutting up. I know it's very strange when I do that. But pause for a minute, right? See, Rich immediately felt like, yeah, people want to say something then. And you leave them there. You're probably, there's a decent chance, Mr. Jones, that you're actually not even breathing at times at night. And just shut up, and who talks first loses. And I guarantee you most of the time they're just going to say, what do you mean? How do I know? Well, we have to have a test. We have to have a test to figure out if that's happening. And if the patient doesn't ask you that question, that's really your obligation, or as I've been saying, your job to tell them. The doctor doesn't just say, well, the patient didn't ask if they needed to have a stress test. We'll just let them walk out the door. No, the doctor tells you, look, you're at risk for having this problem. You need to have this test, and you need to put your doctor pants on, or big boy pants, or big lady pants, and say, look, you've got to have this test. And when you say it like that and you believe in it, patients will say yes to doing it.
I think any normal patient would, Guy.
Yeah.
You know, you said something years ago that Pete Dawson taught you, was, hey, every reasonable person out there wants a healthy mouth. Right. I think every reasonable person out there wants to be healthy. They don't want to stop breathing at night. They don't want to have all of these issues and that kind of thing. But if you don't have a plan at this point, if the guy says, hey, what do I do about that, Guy? And you go, well, you should get a sleep study done. Go talk to your doctor about that.
Yeah, that's not
really. How many of those people will go get a sleep test? Maybe a few will, if you scared them enough or they're conscientious enough, but you've got to have a way to help facilitate this. You've got to have a way to help make this happen, because otherwise it might not.
Yeah. And again, when it comes to testing, you don't know how good you have it, because this was the only show in town when Rich and I first started doing this 20 years ago. The only thing we could tell them, I got to talk to your doctor. I'm going to refer you down to the sleep lab. You're going to go spend the night in the sleep lab. And that still's done some, but far and away, most people are doing this at home now. And since around 2006, 2007, it's been available in our country. And in the last 4 or 5 years, it's become the standard of care. And so the patient doesn't have to go spend the night in the sleep lab. They can do it in the comfort of their own home. And the question always comes up, can dentists be involved in this process? And one of the options for another hour webinar is sleep testing itself. And an hour is not long enough. So we're going to still talk about this at a high level. But the answer to most questions that you might ask is, it depends. So can dentists do this? Well, it depends. It depends on who you're listening to, and it depends on what state you're living in. The American Dental Association, as of 2017, says that dentists should be screening their patients. We're in the best position to help identify these people at risk of everybody out there. It's part of our job to do that, in other words. And we're encouraged to screen our patients. And then we could refer them to physicians for diagnosis. I believe that to be included of being involved with handing them a sleep testing recorder. And that dentists are the only people who are able to really make a dental device for these patients. The only ones really qualified to do that. And we should be able to use these testing units to see how well our devices are working. So that's what the ADA says. And then again, hot off the presses, when was this, Rich? Last fall?
Not too long ago.
It's been less than a year. It's been 8 months ago. The American Academy of Dental Sleep Medicine reached out to all the state dental boards and says, what do you think about dentists ordering home sleep tests or administering home sleep tests in the conjunction of working with board certified sleep physicians to read them? Is that okay to do in your state? And so all the gray states there said, yes, dentists can be doing this. And they can, furthermore, they can be using those same home sleep tests independently to evaluate the efficacy of their devices. So if you live in one of those black states, dark gray states, don't get too worried, or the white state, which is North Carolina, they can be used for titration and not ordering. We still have solutions for you. But the majority of you out there, and the answer is yes, your state dental boards have confirmed that as of the printing of that from the AADSM, I'm assuming nothing's changed, that you can do anything on this screen as far as your testing options. And wow, that's I couldn't say that 6-9 months ago, could we, Rich? It was just a big gray area because we didn't know for sure.
That it was.
Yes. See, there's some questions coming in. We will get to those.
Yeah, I'm typing in one of these now, guys. So
okay. All right. Well, I'll continue on and kind of go over these. It's real high level on this. Again, we could talk for someone asked if I go back to stats. There you go. I'll give you another quick glance of it. At a high level, we can have 3 options. Anyone, no matter which state you're in, can do option 1. You can refer to a primary care. They can order the test. You can refer to a sleep lab who sees the patient, the doctor sees them, and then they administer the test. So in other words, you can work with the medical community to do this, and you can still have home sleep tests. They don't have to go to the sleep lab to do this. So that takes a little more upfront work, but the payoff is that you actually get to meet these medical professionals, and oftentimes those can become referral sources down the road. Options 2 is an option that you can do in those gray states. We could purchase our own home sleep test. We could hand it to them, the patient. The patient can wear it. They can bring it back. We can upload the data to the cloud, however that happens. Most all the home sleep testing units allow a way to do that. And then a board certified sleep physician can read that data and give a diagnosis. In those gray states, that's an easy way to do it. You've got a unit in your office, you facilitate the test that way. There's usually a fee for that physician to read it, and you can work out the finances between you and your patient about how you're going to do that. Now, there's also home sleep testing companies you can refer to if you're in those gray states. But what most of them have converted to are having telemedicine options. So you can also do option 3 if you're in one of those states that the board says you can't order the test. You can refer them to these telemedicine providers. They have a meeting just like we're doing here, but a little more interactive because it's an actual face-to-face where the physician's meeting the patient, and that physician decides if the patient needs a test, and if so, they order the test and send it through one of the medical providers that sends it to the patient's house one way or another. So that's a way you can facilitate sleep testing as well. So really, there's no reason why this should be a holdup in 2021, March 2nd, I think is the date today, because that option.
In case you're watching this 5 years from now.
Yeah, because we do record these. And option 3 was around pre-COVID, but it wasn't available. No one was accepting it. Insurance companies weren't paying for it. A lot of things changed in the last year that made that option very viable today. So you don't know how good you have. You have 3 good options. If you're in 43 states, you can do any of these. If you're in the other 7 states, you can do options 1 and 3. And so, again, we can spend more than an hour talking about these individually. Yes, the answer to the question is, someone's asking, can you refer to a telemedicine company? Yes, as long as they do the telemedicine visit with the doctor first. Then just think of it this way. Telemedicine is just like you referring them to a doctor. They go into the office, except for they're meeting the doctor on the computer. So it's really the same as option 1, except that doctor is not in their office. They're in a computer. They're meeting them virtually like that, as long as that doctor's licensed in that state, which most of these companies have doctors licensed in the vast majority, if not all of the states. So fantastic options you have. If you use DS3, you can even order these tests depending on your state and who you're hooked up with through our software. Rich, you had something to say? Sorry.
Yeah, and there's another question about the cost. We're not doing that consultation. We're trying to help facilitate this for you. You can go to your doctor. He'll make a referral to a sleep doc. It's a much longer process. You have to drive all over town. You have to do all this stuff. We're going to allow you to do this in your own home, sitting in front of a computer. We don't bill for that. Those people do. But when we make this referral, we help facilitate this. Those people are very nice. They will go over all of this stuff with you. They'll talk about your insurance and what's covered and not. And a lot of times there isn't an out-of-pocket, but you won't know until you call them and you do that. That's the kind of verbiage that we use.
Absolutely. And it depends on the patient, their insurance. And I can tell you one thing, if you come to our virtual course, which I'm going to tell you all about in just a little while, it's in the evenings. If you're in one of the gray states, I say get you one of these home sleep testing units and just do it in your own office to start with, set a reasonable fee, and you can provide a great service for your patients. But these other 2 options work as well. And again, we help facilitate that through our DS3 software. If you want to know more about what we do and some of these challenges you have, type in consult either into the chat or the Q&A, and one of our team members will meet with you for free and answer your questions. We have a whole team of dental sleep medicine experts. That's all they do. Dozens and dozens of years worth of dental sleep medicine experience at your disposal. Meet with them and they can answer some of these questions and tell you how we can help you succeed at dental sleep. All right, any more questions on that, Rich? And we can move on to treating because we're about halfway through the slide. So I think we're rolling on along. I know it's a lot of information at a high level, but I hope that it can help start stimulating your thought patterns as to how you need to do this in your practice.
Yeah, and you, like I said, we record these things. You can watch this again. You can get some of your team members involved to watch this, and you can take notes because, again, we're hitting this at a high level. So we talk for hours about how to facilitate these tests and how to get this stuff done. So we're just hitting the high spots again.
Yeah, and again, type in consult. Someone will meet with you. I see a couple people type that in. Now you are going to have to, as you get busy doing this, and even before you get busy, you want to start out the right way. I mean, if you're just starting your office tomorrow, wouldn't you like to have a nice filing cabinet and start being organized from the get-go or before it gets to this stage? And the problem is that dental softwares are made for dental data. It just, for fillings and root canals and all that kind of thing. And dental sleep data doesn't fit into them well. So you need to find a way to manage the dental sleep. We could talk for hours just about how we can help you manage that or ways to manage that. But you got all this data that you're going to need to manage. None of it's difficult compared to doing a denture, root canal, or DO composite. But it's all a lot of stuff that you've got to manage together. That's what we specialize in at DS3. If you want to know more about how we can help you, feel free to reach out to someone there. And finding ways to manage this data will make your life a lot better. So I could spend like an hour or two on each of those subjects, but we're not going to do that tonight, but we can answer more questions. Go ahead.
I'm laughing because Dr. Buskirk said, hey, I also want to learn how to get my team involved. So I will tell you, Dr. Buskirk, that you are on the path to success just because you asked that question, because you can't do this by yourself. We think about our dental staff guy, and the doctor goes off for the CE, and the staff's back there on Monday morning going, oh great, what do we got to sell now? What do we got to do now? But again, once you get the staff involved, I had all 4 of my assistants in the hallway today, Guy, for about 5 minutes, and I just patted them on the back and said, congratulations. We had a patient with an AHI of 47, and we got him down to 0.7. And I said, you guys should feel really good about this. You very well may have saved this lady's life, and they just glow, they just get this. But you've got to get your team on board. And that's a great question. And you're not going to figure that out in the next 5 minutes.
Yeah. And you said you have to have the team. I guess you could do this by yourself, but why would you when most of this can be delegated to your team, and you're going to be happy, your team's going to be happy, and you're going to be much more profitable. I'll show you a slide at the end. I'm convinced, and you're going to have to work hard to convince me otherwise, and no one's been able to show me any way other than what I'm going to explain. Dental sleep medicine can be the most profitable thing per hour of dentist time for a general dentist to do. And that's because most of what you do doesn't have to be done by the dentist. And most of all the other procedures that you're doing do. So you can't delegate the root canal, you can't delegate the crown, but you can delegate the vast majority of these steps that we're going to go into. The consultation even, my team does the majority of that. Exams and impressions, they do the majority of that with the scannings that we do now. The device delivery, they do the majority of that. The 3-week evaluation, I might read the chart and sign some notes or answer a question if they have a concern. The subjective titration, they 100% take care of that. That's adjusting the device based on symptoms. And then we're going to adjust the device based on real data from sleep tests, which we have what we call our fast track now. And they orchestrate it all. All I do is read the data and make a decision, get paid for being the doctor, takes a few minutes of my time. And then a 6-month annual recall. Again, they bring most of the data in. It's just some decision-making and some pretty brief conversations that typically go into that. All those things can be done, again, in about 45 minutes or so of the dentist time with just a little bit of training and some systems in place. I think one of the challenges, Rich, for these dentists when it comes to dental sleep is not establishing goals of treatment per patient. And I think we're not used to that because as a dentist, the goal is put the crown on, fill the root canal. There's a tooth missing, we're going to replace it. Scrape the tartar off. Finish your treatment plan. Finish your treatment plan. But when it comes to dental sleep, there's really 3 goals of how we, when we hand someone a device, what we're trying to accomplish. Now, first thing is we want them to wear the device. But then the second thing is these people are either going to want to wear this device for 1 or 2 reasons or both of them. The same thing for a CPAP. They're either interested in being treated because, number 1, they have symptoms, snoring, sleepiness, waking up at night, that kind of thing. Or number 2, they realize that obstructive sleep apnea is not that so much about sleep as it is about not sleeping and not breathing, and you can die in your sleep from this, and it can cause a myriad of health problems that they don't want to have. And so they're doing it for health reasons, or it's both. And at the consultation, we want to define what the patient wants out of this, both in symptoms, and then we want to talk about what the likely success is from an objective point of view. So in order to do that, you've got to be prepared. And if we could walk into the consultation with a copy of the sleep study, and we know really where they are, then we have a pretty good idea. And we can show you studies in our courses that we're going to teach if you want to attend one of those, to show what a likely outcome is from an objective sleep study. So another follow-up sleep study. Where do we think we can do from a health point of view? And then the patient completes a questionnaire with all their symptoms, and we look at those symptoms. And if those symptoms are associated with their sleep disorder breathing, we talk about what a reasonable outcome likely is for those. And we talk about that at the consult. And also, if we're going to be prepared at the consult, if it goes well, what's the goal? Get them scheduled for treatment, right? They're going to say, let's get going on this thing if they're a good candidate. What's the most common question they're going to ask before they, what is it, Rich? You probably know.
How much does it cost?
How much does it cost? You better have that before the consultation too. You better have an answer. And I tell you, it blows me away. Some of the companies teaching this, some of the billing companies say, well, we do a pre-authorization and then we'll get back to you in 3 weeks. And, I mean, have you ever gone to a car dealer and they said, let me get back to you on the, how much the cost is going to be on that? I mean, it goes against every.
Are you sure you want to buy this car, guy? Why don't you go home and talk to your wife about it?
Go do some research on it and let's talk about it later. You got to have an answer. It's got to be confident. You got to have a system for that. We'll talk about that very briefly in a little while. So the baseline sleep test, I'm going to give you an opportunity if you want to come to one of our virtual courses at the end to get one of 2 free ebooks. Now, one of them, Rich and I spent, it's very recent. It's been in the last year we wrote these, spent hours on one of them that is on how you demystify reading sleep tests. All you want to know about sleep, what's REM sleep, what do all these things mean? What do all these things over here, AHI and all this that's on the screen mean? You can have a free ebook if you come to one of our courses, and we'll give that to you. So again, this is one of the options we could talk about for the next webinar, but suffice it to say, we need to take that sleep test, dissect it in such a manner that we can readily see what their level of apnea is, and even just as important, what a likely outcome is down the road as we test them again. And then we want to have a way to do that, which we'll talk about in a second. So we can teach you how to do that in the DS3 software. It makes that really easy. And then we'll also want to dissect their symptoms. We want to look at their symptoms in such a way that we can actually objectively look at their symptoms. So it's just not like, how are you doing? You're asking a patient, how are you doing? I think you get 1 of 2 answers,
Fine.
Rich. Fine. That's one of them. Fine. I'm okay, because people want to please you, right? Well, what's the other answer? That defines much better than the second answer, by the way. Do you know what the second one is?
Yeah, you don't want to know.
You don't want to know. They tell you everything that's wrong with them since birth, and you're in there for the next 2 hours. Neither one is helpful when it comes to a dental sleep consultation. We want to really define these symptoms. So we break this down in these categories, and we have really it's almost a mathematical system to look at their symptoms. These ESS, TSS, well, those are sleepiness and snoring scales. We look at energy levels and we look at sleep quality, and you'll see in just a few moments, once we treat the patient, we can look how well they're doing very objectively. So you need a system for that. Because I can tell you, when I first started doing this, I'd hand them the device and I'd go, well, how do you think it's working? Well, you're the doctor, tell me. I don't know, I guess it's okay. And you just kind of felt lost at that point. So at the consult, we want to think about what those symptoms are and what the likelihood is of us addressing those and give reasonable expectations. And then we want to do an evaluation on their insurance. Through DS3, we have an instant eligibility check. We can instantly figure out what the patient's benefits are. And through training, through dental sleep billing courses, or through using a third-party biller, you will be able to answer that question, how much is it going to cost me? So you can be prepared for this consultation. So you have those 3 things: the sleep test, the questionnaire, and the answer to the one. And that's a good question, isn't it, Rich? I think some people, when someone says, how much is it, that everybody clams up and they're worried. And to me, that's means
great, because they're interested. That means they're interested.
Yeah, they want it. Don't let that freak you out when someone says, how much is it? Go, I'm glad you asked. And you should be glad, because that means they want what you have. We just got to figure out the finances on it here. So be prepared. we go through these consults, take in our office about 30 minutes. My team does a lot of this. I know, Rich, you do yours a little different than ours. We do a lot telemedicine now, and we can talk about that in a future webinar. But the idea is we want to go through what's going on with them, explain them what apnea is, talk about treatment options. And really the goal here is to let them know, are you a good candidate for a dental device? And we kind of hold that carrot in front of them. Like, Dr. Yatros will be in a little bit, and, if you're lucky, he's going to give you one of these dental devices. And if you're a good candidate, if not, we're going to give you a CPAP. It's almost like you're threatening with them with the CPAP. And and they're like, oh, I don't want that, because we have one right there to show them. And I walk in the room. A lot of times, Rich is I just like want to high five my team when they go. I walk in, hey, I'm Dr. Yatros. Nice to meet you, Mr. Jones. He goes, I hope I'm a good candidate for this. That's right out of their mouth. Wouldn't that be fun if that was your crown patient? I hope I'm a good candidate for that implant, doctor. I really got the $5,000 in my pocket burning a hole, wanting to fill that gap. So again, this is one of the questions we could ask for the next webinar. In detail, we could talk about this for an hour. I know that we're going to talk about our symposium coming up. I know Dr. Mark Murphy is going to be talking about getting patients to say yes to treatments. I know he's going to go into great detail about this as well. But I think being prepared is the main goal to be successful at this. And so assuming the patient says yes to treatment, we're going to now see them and begin treatment. And I think I used to spend a lot more time on this appointment than I do now. I haven't asked you this in a while. How much of your time do you spend on the new patient exam? And I have impressions here. We probably ought to change that to scans. 5 minutes?
Yeah.
That's about.
I mean, we make almost 1,000 of these things a year out of my office, so we're doing a big volume. So that's maybe not fair if you're just starting out for this. But when you look and you hear their joint, and they open and close, and you palpate their masters and a couple of muscles, and you look at Mal and Patty, and you do all this kind of stuff. So it really doesn't take too long, once you do that. And people, oh, wait a minute, TMJ issues. I will tell you, don't let that scare you away. Most of the time our devices make the TM joint healthier and better. They really do. So occasionally they make it worse, but you want to document that stuff. So anytime, the TMJ flag goes up, we spend a little more time, Guy, documenting clicks and pops. And, because it comes out sometimes 3 months later, people go, my jaw's clicking again. And I go back to my consult note and I said, oh, you mentioned that, in your consultation that sometimes it does on the left side. And they go, oh yeah, that's right. It does. So again, you got to document this stuff, but all of this stuff that Guy's talking about, from the symptoms and the Epworth and, where do you put all of that stuff? If you don't have a software or a management system to do that, then it just makes it more difficult. If you're going to keep a paper chart on your sleep patients, because the dental softwares don't have a place to put this stuff, then you have to put it all in a progress note or something. And it's just not very organized. So, I just can't emphasize enough, Guy, that this isn't that hard, but it is different.
I would say it a little different than that. It's not hard or difficult. It's complex. There's just a lot of pieces. I don't mean complex. Complex to me means just a lot of little parts. It's like a puzzle. You just got to get the pieces together. None of the puzzle pieces are difficult to do. So this is the information we're going to gather. We do have ways of making this easier by having little check boxes for things like the tonsils and the TMJ and so forth. And one of the main parts of this exam, really, I would say the 3 parts of the exam that are most important. One is your documentation, because if you're going to bill insurances, that can be important. Number 2 is to look at the range of motion, decide where we're going to start the device. And number 3 is which device you're going to use. And most devices will work in most cases is the answer. And we could probably get by with just one device in most cases, but sometimes one device might work a little better than other based on the anatomy. And we have a whole hour webinar where we could talk about just that. But I would just like you to relax a little bit on that and realize that's one of the biggest questions people have, but it's probably the least big hurdle that you have, because all the devices on the screen here work, and we do them all. And if you only had one of them, you could probably get away with it. So
I like to say, Keith Thornton is the guy who invented the tap. And I'm pretty sure when he does a consult, he doesn't have any problem picking out which device he's going to use.
And you know what? The tap will work.
He's done pretty well for himself. That's right. So
hey,
I like to
right
teach
there.
I like to teach that, you can't make a wrong one, but maybe you can make a little better one. And that's something that you'll learn as you do that. And we have webinars to help with all that kind of stuff.
Yeah. And again, if you want help on just this subject and it's not one of our upcoming webinars, type consultation. Free consult. One of our team members will get with you. They'll go through this. They also have a lot of resources at their disposal. So we have other videos we can share that are private videos that for our members, but they'll be happy to share them with some of you all if you're not a member, just to help you through some hurdles to show you how we can help you. So if you want to know more about dental devices, type consult dental devices. Someone will meet with you, give you a link to one of our webinars that are teaching or programs that go through those devices for you. And so once we do this, most of the devices take 3 weeks or so to get back. And then my team really does all of this part. They fit the device, they make sure the patient can take it in and out twice. They make what's called an AM aligner that gets their jaw to reposition. And we'll probably talk a little bit about that in the preventing TMJ and side effects. We'll certainly be talking about that in the next webinar. So we'll show you how you make one of those, at least tell you how to make one of those. And it really prevents side effects. My team does all that. The patient can take it in and out twice, then they put it in the mouth and they come get me to come check it. I like the device to be in the mouth when I come into the room. Rich, do you know why that I prefer the device to be in the room when I walk in?
Because they don't talk as much.
Because the patient can't talk to you. Saves time. It's efficient. The patient's got a mouthful. If they're a talker, you're one step ahead of the game. And that's partly it. And I kid. It's really not the most reason. The main reason is I live here in Florida where the average age is old and ancient. And you got these people and they're going to put this thing in for the third time. They're going to, let me put that in, Dr. Yatros. And, I'm ready for retirement by the time they get the thing in their mouth for the third time. And so I'd rather not be part of that process and let my team deal with that. And so I can come in, I can look at it, I see how tight it is, I take it out, say, I do give them an opportunity to talk. I kid about them not talking, say, can I answer any questions for you? And I reiterate the 3-step process that you're going to wear the device, that you're going to, we're going to address your symptoms, and then we're going to do some sort of follow-up testing. And really that appointment takes, once you get this down, 5 minutes of time. Now, I do want to pause. So we keep saying that. The first case you're going to do, if you haven't done it, it's going to take you a lot longer than it should. You're learning how to do this. And you should do a lot of these steps yourself if you're the dentist until you're comfortable doing them. And then you can delegate them. I found through our teaching of other dentists that that you do a dozen or two, try to get 20 under your belt, and then you're going to have a system in place that does this pretty well, and you can start delegating. You're going to find you really, really enjoy doing this. So once we deliver the device, they're going to come back for follow-up evaluation, and we do this sometimes via telemedicine and phone now. And the process is, are you wearing the device? That's step one, remember? The answer is no, then we're going to figure out why not and make adjustments on that. I can tell you most dentists can kind of figure this one out on their own if they've been a dentist for any period of time. If you've ever done bite guards, dentures, partials, fit bridges, usually it's just something you've got to adjust. And most of the time they are wearing it is the good news. And so if they are wearing it, we're going to say, is it working? And we don't just say, how are you feeling? We're going to say, we're going to go through this in a systematic manner by filling out those questions again. If the answer is no, we're going to have the patient typically adjust it maybe a 0.5 millimeter to a 1/4 millimeter to a 0.5 millimeter more forward each week for a few weeks. And then they need to ask themselves, so we'll ask them again, is it working? And once they feel that it is, we're going to do some sort of follow-up sleep test. And today we do what we call fast track calibration. It's very new that we've been doing just in the last 6 months or a year. And so kind of walk you through how this works with a patient. Any question? I'll saw you answering a question there, Rich. Anything to add on that before I actually showed them
No, we're just kind of talking about, who would not be a candidate.
Yeah.
People don't have any teeth. They don't have any implants. They have nothing to grab on to. Class 3, they don't have any range of motion.
Right.
We actually made a device, Guy, for a lady. She was about 40 years old, and both of her TM joints were prosthetic. She
Oh,
had them
geez.
put in with metal. I'd never even seen this before. And we could barely get her mouth open enough to get scans. We actually made her a dental device. She had no protrusive range of motion, and we took her from moderate to no sleep apnea at all. Again, just because her jaw wasn't falling down and back. So, just because somebody doesn't have protrusive range of motion doesn't necessarily mean that they're not a candidate.
Right.
But those are just a few things, and there's a few more.
All right, well, assuming they're wearing the device again, and they come in, and let's say these numbers are how sleepy they are. These numbers we hope to be under 10 for this one, under 5 for this. If you don't know what these numbers, Thornton snoring scale, and the snoring on the 0 to 10, and we ask them the questions again. Look, are you snoring? And so we just put them right into our spreadsheet, or in this case, it's into our software. It makes life a lot easier. And at a glance, we can see we've improved these numbers. The energy level, sleep quality has gotten better on the patient. And then we ask them the question, I know, Mr. Jones, your chief concern was sleepiness and snoring. Have we achieved what you expected out of this, or what we agreed we would accomplish? If he says yes, we're done with step number 2. If he says no, I'm still a little tired, we're going to go ahead and move the device a little more forward over a period of time, and then we'll fill out another column like this down the road. Assuming we get to where he or she is comfortable with their symptoms, and the majority of the time you honestly will. And then sometimes you say, all right, I've fiddled with this long enough, I'm going to move on to stage 3 too. And some of the other, and if you come to one of our courses, we'll go into that in a lot more detail about how you make that decision. But nowadays, just in the last year, in the last 12 months or less, we've come up with what we call our fast track calibration. It's something that we at DS3 kind of came up with and have really tested on hundreds, if not thousands, of patients now. And really what it amounts to is we have the technology now to give to our patients. It's called the Night Owl Mini. It's a disposable level 4 sleep recorder utilizing PAT technology. And we include this in our treatment plan. And if the patient gets this, and I can test the patient up to 14 nights without the patient coming back in. And what we will do is, if this was the baseline sleep study, we'll test the patient at multiple places forward over multiple nights in a row. And then we'll have all the data to make a decision about where the target position is for that patient. So we can look at the numbers lowering. And again, you may not know what all these things are, and some of you do, I'm sure, what AHI is. But if we look at the numbers going from 29 to 6 and the oxygen levels going up, we can look at this. And with some training, if you want that ebook, if these numbers are all Greek to you, then you might want that ebook that explains those to you. We'll be able to make a decision as to really where the best position for this patient is. And that's what Rich said at the beginning. This used to take us months. Now, after the patient's comfortably wearing the device, we can do a multi-night, multi-day in a row, fast-track calibration utilizing the Night Owl technology from the Mini HST site. And we can know where we're going and get there very quickly, which we couldn't do before this technology was here. Because before, even 3 or 4 years ago, the most any sleep testing could do would be 2, maybe 3 nights in a row. They had to bring it back in. You had to download it, upload it. And now with this tech, and we didn't have enough units to go around for people to be keeping it for a week. So with this technology, that's where you can get the Mini HST. If anybody's interested in that, you can take a picture of that. And I think it's in the
Guy,
chat.
and I love John Rimmers, and I love my Rimmers recorder, that I bought 20 years ago, and I paid $16,000 for it, at the time, and it records 8 hours of data, and that patient has to bring it back in. And
right.
Honestly, I hope 5 years from now we're looking back at this and we're laughing at how archaic some of this stuff we're doing is, because we certainly would, now compared to 5 years ago, even what we were doing. And these options weren't available. We didn't have something that costs $100, $150, whatever they cost. I don't think they're that much. And, now this patient doesn't even have to come back in the office. It just hooks up through Wi-Fi. And I actually have the ability to test a patient at multiple positions over a shorter period of time. And we can reach that target position much more effectively.
Yeah, and I'm talking about that for a whole hour in our symposium that's coming up, and we'll call it the Fast Track Calibration, and we'll walk you through that. And if you come to one of our courses, we walk through that process as well on how you do this. And it has revolutionized what we do from the time we give them the patient the device. It used to take months. Now it's a matter now it's a matter of days. Question is, do we charge for the night owl? I include it in our treatment with most cases. Rich charges an extra fee, I think, for it. It really comes out to the same thing. We know what we want for our patients, and it can depend on whether you have in-network or out-of-network billing. And it's just something that you can figure out which system is better for you. The fees for this are under $100. And what I've realized is even if I pay that out of my pocket, it is saving our team a ton of time by not having to, here's a sleep recorder, take it home, bring it back in. Now we're uploading it. Now we're reading it. Now you're taking it home again. And I got the capital cost of all that equipment. In time savings alone, it's worth me paying it out of my pocket to fast track this sleep test going forward. Okay, we'll talk about billing very briefly. It's a big pillar here. We have a whole billing course coming up that I'm going to offer to you. And really the quick question here, or quick answer rather, is let someone else do this for you while you're getting started. Now, we have our own billing company. That may sound a little self-serving, but we encourage you to do your own billing at some point if you want to. But as you're starting out, you've got too much else to worry about. Let a third-party biller, we have companies that just do billing for dental sleep, and let them do it. And furthermore, I would even say, let's don't worry about medical billing on the first dozen or two cases. Let's set a cash fee that's reasonable, that patients will say yes to, and that you can get started, because this pillar of billing can sometimes be such a hurdle that it slows people down. So I know we did a pretty fast and furious steps of dental sleep. We can help you in detail on each of these steps. If you want more information, just type consult, reach out to us at our email. We'll be happy to meet with you. I'm going to talk to you about how you can get those ebooks in just a moment. But here's where I want to mention again that dental sleep medicine is the most lucrative thing a general dentist can do with his or her time, because most of this can be delegated. If you just did one device a week, after you pay for the device, after you pay for our services, after you pay for billing, you're still going to add like 20 grand a year almost to your bottom line here. If you do, that's one a month rather. If you do one a week, you're going to be pushing 6 figures that you're adding to your dental practice just by doing one a week. 1 in 5 adults has this problem. I mean, 1 a week is not a stretch for anybody on this webinar, even if you're brand new to this. Then imagine doing 2 a week or 3 a week. Now you're rivaling half the production of a lot of dental offices entirely. So that's why it's going to be extremely profitable, because you as the dentist can add this to your practice, it can run in the background. It did in my office for many years. I just do dental sleep now, but up until 2013, this was running in the back of my busy dental practice, and it was just another service that was running. It just, I got so busy with it, and I followed my passion and decided to go with just this. So if you want to get started doing this, start by screening your patients. You think Rich and I are off our rockers here? We don't know what we're talking about. Go screen your patients. You're going to find 1 in 5 of them need your help. And then I would say even just start treating some of those patients, even if you don't have a sleep test. Give them one of these mandibular advancement devices and let them start feeling better. Let them stop snoring as much. And then we can test the patients. Ideally test them first, but sometimes if you don't have your testing unit there, let's go ahead and start treating some of these people. You're going to find how much you can help. Rich already mentioned this. Best question of the night, involve the team. Involve the team, because if the team gets on board with this, they're going to love it. What they're going to love about it is, I'm a believer, we're believers at DS3, that team members don't want to just suck spit and sit there in a chair and hand instruments. Team members want to feel important. They want to be valuable. They want to contribute to the overall picture. And there is no other service better than dental sleep for team members to thrive and to become extremely important. They're helping save and extend and improve people's lives. And so it's a really great opportunity for motivated team members. And if you want to know more about how it can help you, schedule a DS3 consultation. It's free. You're going to get a lot out of it. No one's just going to try to sell you on what we have. We have a lot of great things to help you with for very reasonable amounts, but that's not the purpose. The purpose is meet with one of our team members. They'll help you answer. I know you got a lot of questions. You got these questions, say consultation. One of our team members will get on with you, and we will help answer your questions to get you going on this, because it can be a whole lot of fun and a whole lot of needed difference in your dental practice, because dentistry can be stressful. I've been a dentist for 30 years. Dentistry can be stressful, and dental sleep can add just a little bit of diversity to make this a lot better. I know we're answering a few more questions, going to be finished right here on time. If you want to know more how to do this, we do, and I'll be doing this myself. And it's a course on March 23rd and 24th, 7 to 9:30 Eastern. Now, it's a different format. We have hundreds of people that signed up for this tonight. And so this was done during the webinar. We use Zoom meetings. So you'll be able to ask questions, unmute yourself. It'll be just like we're in the classroom together. And the most common feedback I get from these courses are, wow, that's just as good as traveling halfway across the country. It goes from 7 to 9:30 those 2 nights. That's 5 hours. But if you attend, we have an additional 4 or 5 hours of content available to you to fill in any of the gaps as well. And you also, you get one of the free ebooks. One of them is on demystifying the sleep test, if you choose that one, or the other was on that fast track technique that you want. They're $30 value. You can get those for free. You also can attend this billing course. There's a CR code, by the way, if you want to scan that. You also can attend this billing course for free. The next one's May 7th, or you can watch one of the recorded ones we have. That's included in your tuition. Or if you just want to learn the billing, Lisa Hurt's been in medical billing rather for 25 years. She knows more than most people have forgotten, and or however that saying goes, is the lady, the person to answer your questions. It's about 3 hours of CE, live interactive. You'll be able to answer questions. You'll be able to turn on their cameras. You'll be able to get everything going out of it. You get to come to that for free if you do this course. If you want to come to just it, then you can go to the course for just $200. And you're even going to get a marketing kit along with a provisional device, a MyTap provisional device, about a $400 value for attending that virtual GPS course. We call it the GPS course because we want to teach you to navigate the hurdles of dental sleep. Okay, that's a big mouthful of lot. I know, Rich, I've been talking on, there's the website. I do want to mention one last thing, and then we'll answer more questions. The North American Dental Sleep Medicine Symposium is virtual this year, April 9th. We have 10 great speakers, 2 of which I've been trying to get to come for years. I think Sharon Moore, I think she lives in Australia, couldn't get her to come to the live event. Brad Bale, he wrote the Beat the Heart Attack Gene. Wonderful cardiologist. I was going to talk about inflammatory process and how that affects dentistry and sleep apnea. I've been trying to get him to come because it's virtual. We got him to come this year because of their schedules. Rich, I know you're talking about the Department of Transportation and what that means. I'm talking about the fast track calibration. Dr. Mark Murphy's talking about consultations and getting patients to say yes to sleep testing and consults. Ron Prain is talking about CPAP and
combination therapy, hybrid therapy, all that kind of stuff.
10 speakers, 13 hours, and you don't have to be there that day. It is it's aired live April 9th. The first 3 hours are really keynote speakers with just the real important information and a live Q&A, but it's all recorded and on demand. And there's an option for under $100 if you just want to attend. If you want CE, it's a little more, but look, check it out. It's going to be a great event. I think well worth the time and effort. All right.
Yeah, Sharon Moore's going to talk about kids, pediatric stuff. So
yeah, she wrote a Sleep Wreck Kids book, and that's what she's going to talk about. It's a great book. And actually, one of the options, you get her book included with the tuition. So, all right, I finished.
Couple of questions, Guy.
Yeah, go ahead.
Is DS3X billing service in Canada available? Lisa, I'm going to let you answer that one. I don't know. Here's one, Guy. Tell me if you can figure out what they're trying to ask. The night owl is used to track the success instead of referring back for new sleep study in areas where dentists must refer for study prior to treating. I'm not exactly sure I understand that question. If you can clarify that a little bit, Anita, that would be great. But keep in mind that, you don't have to have a baseline sleep test, but you really should have one in order to treat a patient. And that's not done by us as dentists. We can do the test, you can upload it to a cloud and get a diagnosis, but that's one of the ways that Guy talked about that. But that can be difficult, and that can be a challenge with some insurance companies. We're talking about using the Night Owl and the minihst.com to titrate our device, to do multiple nights at multiple positions. So again, if you can clarify that a little bit.
Yeah, I think maybe what they're asking is, is that the final sleep test? Maybe that's what they're asking when they're finished. And
Yeah,
if that's the question, then so yes, we have a diagnosis wherever it came from before, whether you did it in your own office or what have you. They're diagnosed. I treat them. I give them a night owl. Got one right here, as a matter of fact. This little show what it looks like. I give them one of these night owls. Well, I just dropped it. Oh well, there we go. I give them one of these night owls. They just tape that to their finger. It goes to their smartphone. I get all that information off over the 5 or 6 nights. I say, here's the target position. I want you to titrate to this position. I'm done. Now, I take that information and I share it with their physicians. And I say, we calibrated them. That patient is at the best position by my professional judgment. I know that because I've calibrated it by looking at the various nights. And I'm referring back to you, Dr. Smith Jones, whoever that is, for any further treatment or tests as you see fit. Now, some of them might want to do their own tests, and that's fine. But what's nice if they do their own tests, we've got them at the best position. There's none of this coming back to me and we're going to move them again. If they do their test.
Or, Guy, we get to test them at one position and the doctor says, it's not working. You need to throw that thing away. And when I do my lecture for the symposium, that's what I'm talking about, is one of the reasons that physicians think we don't do a good job is because we don't do a good job of calibrating the devices. Well, I said the other day, Guy, I was doing a lunch and learn with a doc, and I said, that's like, I feel like I go to work every day with one hand tied behind my back. Right. He said, what do you mean? I said, well, you get to pick one CPAP pressure. And if you're too high, you lose.
Right.
So what pressure would you pick? He goes, well, that's ludicrous. You can't do that. I said, absolutely. Why are you asking me to do that with a dental device? I need to test all of these different positions. This just allows us to do that. It's the first affordable way that we can actually do that without, and it all goes to the cloud and we just log in and we see it. And my assistant gives the doctor, a task to review that, and they putting it all in DS3, and I just go in there and it has all the different device positions and all that. You can teach a monkey how to do that part at that point.
Absolutely. And back to what I said too, oftentimes when I send them back to the doctor, most of the time they just say, great. They don't do a follow-up test, at least in my offices. Most of them just say, hey, that looks good to me. I send them the reports. And it's up to them. So if that was the question, if you want the fast track calibration book, yes, we do sell those. We're actually getting those put up on the e-commerce site, but you can type in a support ticket or send us an email to get just the book if you want that. And do you use the night owl as a screening device? You could, and that could be. I forgot. We're going to do a poll here too. So while we're doing this, I'm going to do the poll of what you all want to talk about next.
I will say, Rich, you can do that, but you need to be careful. And the reason for that is if I use that as a screening device and it comes back and it has an AHI and an LSAT and that, I'm tempted to say, hey, this says you have sleep apnea. Well, the powers that be say I'm a dentist and I'm not supposed to diagnose this. And yes. I may have just done that. And I may have even excluded a diagnosis, when I've not done that. So we don't recommend that you do that. I mean, you can do it, but you have to be very careful. And that requires a little more thought and a little more conversation than what we can do here. All right. What's the question, Guy?
Well, this is just about what you want to talk about next. We do have the next one coming up, but we thought, so was Steve's idea, said, let's poll everybody. If you want your opinions heard, tell us what you'd like a future webinar to be on, and we'll gather this data. I can't tell who's voting for what, so we'll leave it up for a few more minutes. I agree with what you said there, Rich. I have used it in the past, but what I'll tell you is that goes back to being a crutch. You feel like I need to show them something to make them get the sleep test. And if you believe in what you're doing and you believe it's your job to do it and you go about it like you've got to do this, Mr. Jones, they'll get the test and they'll get the validated test. And that's just an extra step. If you must do it that way, then I would recommend using a pulse oximeter for that, because that's not a sleep test. And so I think you're probably a little safer, but either way, it's really a step that once you become confident in doing this, it's just not necessary. The patient, you need to have a sleep test. It's a few $100 at the high end. Go get the sleep test.
And there may be an appropriate patient occasionally, Guy, your buddy that you hunt with or something like that. You know what I mean? But again, that requires a little more thought. It looks like, Guy, People
share the
want to,
results there.
yeah, dental sleep device selection, 1.
Right.
Networking with physicians, I think, was 2nd.
Yeah, and I'm assuming, Steve, you're on here. Someone can take a screenshot. I'm sure that will probably, it has that data for us. I'll take a screenshot just to be sure. There we go. All right, so we'll have that. We do have the next one coming up already confirmed, but we'll take your advice and very likely do dental device selection coming up in a future one. So that's great. Your opinions matter to us. We hope that that we can help you do more of this in your practice, latest advances. So yeah, the network is enough physicians to stop sharing. Let me review these slides once more. Someone typed in that they wanted to see the course again. So let me go back to that. There's the course information. What else? Is Maryland to provide HST to the patient. So the question here, Rich, is, yeah, go ahead.
You know, you can make a dental sleep device on anybody you want, okay? They don't have to have a sleep test. A lot of this comes about because we want to get this dental device paid for by their medical insurance.
Right.
So if you have a patient who's snoring and they go, look, my wife kicked me out of the bedroom years ago. Can you just make this for snoring? I can, but I'm not so sure I would recommend doing that. Why? Because you might have sleep apnea and we would want to know if we're treating that. So yeah, sometimes I've even made dental devices like that, Guy, and then we end up testing them later. We do something like that. So you can do that.
I think the question, yeah, so you're right about that. But I think the question is, I'm not sure off the top of my head if Maryland's one of the states that were gray. I should memorize those states, but if you're in one of those gray areas, and if you don't know, email us and we get our email up here too for everyone. I'll get that to you. If you're in a gray state, yes, then you can provide get the test, have it read by a board certified sleep physician. You go ahead and make them a dental device. Now, if you're going to bill medical insurance, there's some other hurdles you may have to go through depending on the insurance. But to be legal by your state dental board, if you're one of those gray states, you're above board by doing it that way. And that's one of the reasons I recommend the cash model when you first start doing this, because you don't have those restrictions that you do with medical insurance. So just a cash model is perfectly legal as long as you're in one of those gray states that said it was legal by your state dental board. That's who determines that, not Rich and Guy, not the AASM or AADSM. It's the state dental board says whether you can or can't do that. And 43 states said yes. And I think the AADSM is working on the 7 that didn't and trying to get that changed in the other direction now, even, which I was surprised to hear. Anything else in the question and answer? I saw someone said, think that it was a good course. We appreciate the feedback. We work hard on these. And just like you and your patients say, thank you for my veneer today. We appreciate the accolades and the thank yous for these courses. We really enjoyed doing them. All right. I'll put it back on this for one more moment. There's the next course and there's the symposium. I don't see any other questions coming in. Do you?
Yeah, I want to encourage people to look at the symposium seriously as well, because it's all broken up in 1 hour chunks. Right. And, you know, depending on which you do, you have access to it for quite a bit more time. So you can even get your team involved and things like that. So, right. You know, and we talked a little bit, Guy, about getting your team involved because one of the docs asked that question. Right. And you know, I think more than anything, as a dentist, you have to be a good leader, especially when it comes to this. You know, your staff doesn't have any trouble at all, you know, drilling a tooth down and putting a crown on it when it's got a big old ugly silver filling in it or something, you know, because they know the patient needs it. They've seen the teeth crack and they've seen this end up people losing teeth and stuff like that. This is a little more difficult because you can't see it. You know, we can't see that tongue falling back. We can look in the mouth and we can do this. So there is a process of educating your staff and like Guy said, empowering them to be a part of this. So for you dentists who don't like to delegate things, you're going to have a harder time getting your staff involved. For that reason, because you don't delegate those things. You know, for those of you who do delegate things, you're gonna, well, you know, some of my staff, Guy, they just they just love coming to work and they love their job, because they really feel important. They're really helping people.
Yeah, let me say this too. If you want to come to one of the courses, what's great about it is your staff can basically come for free. I mean, if they want CE, it's different, but you come as an individual, but then you're going to get a recording of those courses, that virtual course that we're doing in March, that you'll have access to for a month. So you can take that back with your team, sit down and let them watch the course too. Doesn't cost you anymore. So for a few $100s, you can come to the course, you can get the CE, and then you can give your team access to the recording. If you want them just to watch a certain part, they can watch just a certain part. And so it's a great way to get your team educated, as opposed to when we do in-person courses, you got to fly across the country and then it costs you hundreds and thousands of dollars to have them there because there's food and all that involved. So great way to get you. Yeah.
Somebody on BiPAP wants a consult for a dental device. Should I talk with them? I only work with Sleep Doc as far as fabricating devices. Absolutely. Why would somebody be on BiPAP? What is BiPAP? CPAP is a constant level of pressure. BiPAP there's a smart chip in that thing. So when I'm inhaling, the pressure is higher. And then when I start to exhale, instead of having to exhale against that high pressure, the machine lowers the pressure. So somebody on BiPAP might be on 16/12. That's the inspiratory and expiratory pressure. And we move to BiPAP when the pressures are very high, because it's much more difficult to wear PAP pressure when those things are high. But that doesn't necessarily mean that you can't use a dental device on somebody like this. So absolutely, you should consult with them. You should do all those things that you talked about, Guy, prior to the consultation. Get a copy of his sleep test, find out what kind of insurance he has, just go down all of those steps and do everything the same way.
And another on that subject is, if someone calls and says, do you do sleep tests there? The answer is absolutely. We can help you with a sleep test. Come on in, because once they start hearing that you're doing this in your practice, you're going to get people calling out of the woodwork, because I'm telling you, this is a very popular subject. I went to I met a couple over the weekend. Someone had a party and birthday party, and I was invited. Both the husband and wife are coming next week. You mentioned what you do for a living, and they're both they're both going to be patients now. You mentioned you're helping people with snoring and sleep apnea, and people want to talk to you. And so if they say, hey, can you help with the test? Absolutely. Because look, we'll get them in the funnel. We can help them with our own tests. We can refer them. It's a good opportunity for all that. So anybody who wants to come in and talk about sleep-related problems, we're going to see them. We're going to talk to them, and we're going to get them to the right people. And it's just try this. I think if you one last thing, and I know everybody's you can go anytime you want, but if you don't believe me, the next time you meet someone and they say, what do you do? Say, I'm a dentist, but what I do now is what I'm really doing a lot of is treating people with snoring and sleep apnea with dental devices. See how much more engaged they are in that subject than when you just say I'm a dentist. Because unless they broke their tooth in the last week, they're going to say, I hate my dentist. And, that's always a big joke. And then they laugh, and we're supposed to think that's funny some reason. And, and it's just much more, because I don't think, high suicide rate. You all know what has the highest suicide rate. I'm like, okay, it's going to have the highest murder rate here in a minute if this conversation keeps going. I've said before, but, just tell them that, I work on that, and you'll find these people are very excited about talking about it. It's something that's very engaging. So,
hey,
please,
Guy, can I tell one funny story real quick? So I used to have
I don't have a choice, right?
You don't have a choice.
Oh, I do have a button here I could hit. Go ahead.
I used to have a magnet, and I put it on the side of my truck, and it said, save your marriage, stop snoring, with my phone number. They were like $50 a piece. They were like this big, and I put it on the door of my truck. I quit doing it because all 25 magnets that I had were stolen within about 6 months time frame.
Really?
Yes. But I'm at the gas station one day, and this kid's getting gas. I say kid, this 35-year-old kid's over there getting gas. And he looks at my truck and he kind of laughs. And I go, oh, this? And he goes, yeah. And I go, oh, you think that's funny? And he goes, no, man, I wish it was that easy.
Oh, really? That's funny. Well, that's
all right. Well, thanks again, everybody, for joining us.
Yes. Thanks again.
A lot of fun.
I think that's all the questions. I'm going to hit the end button unless anybody feels different.
Thanks, guys.
Seeing you, my friend. All right. Good night, everybody. See you next time.